Thank you very much for taking time out of your schedules to join us today. My name is Vivian Ho. I'm the Baker Institute Chair in Health Economics, and I've had the great fortune of hosting these biennial conferences. This is our 5th one now, so after 10 years, it's nice to have so many familiar faces and new faces coming to these conferences. And every year I have to come up with a new title. And so this year it's like, oh great, I can call it the anniversary edition. And I thought, well, I'll be able to reuse this title in the future at some point. I think it seems fairly certain that the Affordable Care Act is going to stand, and so at some point in the future we'll be able to have another anniversary edition looking at Medicare and the Affordable Care Act in the future. And it will be interesting to come back at some point later on in time and see how these two programs have changed and that have so dramatically affected healthcare. The work that we do here at the Baker Institute, we are constantly growing, and I think some of you have attended our conference a very successful conference we had earlier this month on neglected tropical diseases with Peter Hotez and Jennifer Herricks, who is a postdoc in that area. We have a conference in telehealth that's coming up later this month that Keonta Moore will be working on, and we're actually getting ready to recruit a fellow in global health, and so that will be something exciting we'll be adding to our program in the coming year, we hope. And we can't do this work without just wonderful supporters. You'll notice that we've created a new center within the Baker Institute. It's not just the health policy program anymore and biomedical science and things. We've created an umbrella organization, the Center for Health and Biosciences, and that was we haven't necessarily added new personnel because of that, but it just allows our different groups in neglected tropical diseases, health policy, and our biomedical group to do more synergistic work. So that was due to the Ellie and Virginia Simmons agreeing. They received the Baker Prize this year from the Baker Institute, and they directed the funds that we received, that we raised as a result of that gala, toward the establishment of the center. So we're very grateful for that. And of course, we're extremely grateful to our Health Policy Forum members who also give us really the core of the funds that allow us to do our domestic health policy research and also to host events like this. So with that, I'll get started. You're going to see a terrific slate of speakers today, and I'm just going to go ahead and introduce the first one. If you've come here before, you'll notice that I tend to put the most junior speaker first on the program, and then people are always pleasantly surprised. They go, who is this person? They say, oh, I actually learned quite a bit from him, and this is going to be no different. We're delighted to welcome Professor Jason Abaluck with us. He is a professor at Yale School of Management, and he's done a lot of work on sort of consumer behavior choices and potential sort of what affects decisions that consumers make and what we might think in terms of mistakes consumers make. He's looked at this research a lot in terms of health insurance. He's also done it in terms of the area of obesity, but I don't think he's going to be talking about that today, but who knows, it might get in there somewhere. So without any further delay, I'd like to welcome Dr. Abaluck. The usual sort of speaker rules. The speaker talks for 40 minutes with no interruptions, and then you get 20 minutes of time to ask as many questions as you would like. Thanks, sorry.
All right, so thank you, Vivian. I am delighted to be here today to talk about mistakes. The last time I gave a lecture on mistakes, I forgot my ID card, was locked in the basement of the building, and came sprinting in several minutes late. So today you will just have to take my word for it that this is a subject that I understand at a very deep level. So I'm going to talk about two types of mistakes today. Mistakes in health plan choice by consumers. That's going to take up the bulk of the lecture, primarily because it's something which there is a large and well-developed economic literature on, and we're very close, I think, or at the point where we can make some useful policy recommendations. And then at the end, I will talk a little bit about mistakes in medical testing by providers. And I'll try to convince you that this is a topic while a couple of economists have been looking at it recently that really deserves more attention, both from researchers and from policymakers. So when I talk about mistakes, what do I mean by a mistake? I don't mean that someone is doing something blameworthy. I don't mean, for example, that, oh, they were really stupid by doing that, they should have done something different. So a mistake in health plan choice, all I mean is that they would have been better off if they were enrolled in a different plan. So that might just be because, look, it would have taken them 10 hours poring over insurance documents to figure out which plan is better. It's not worth their time to do that. So they're doing the right thing not doing that. But nonetheless, as policymakers, we're interested in knowing that they would have been better off had they been enrolled in a different plan. And likewise, when I talk about mistakes in medical testing, what I'm going to mean is that there are certain factors that physicians are not weighting appropriately when they decide which patients to test. Now, that might be because there's incomplete information, so the physician just didn't have access to that information. It doesn't necessarily mean that they're doing something wrong given the information available. But what we would like to know as policymakers is that given the totality of information in the world, they could have done something different and better. So I'm going to start then by talking about mistakes in health plan choice, and specifically talking about, first, what is the evidence that we have that people make mistakes? Then I'll talk about why we care that people make mistakes. And finally, I'll talk about some proposed policy solutions. So the first thing to note about health plan choices is that we have very good evidence that beneficiaries do not minimize costs when they choose health plans. What I mean by that is that we can take their realized claims for a given year. We can say, had they been enrolled in each of the different plans in their choice set, what would their costs have been in terms of premiums plus the out-of-pocket costs they would have paid for those claims in each of these different plans. And we can see they're not choosing the plan that minimizes those total costs either in a realized cost sense or in an ex-ante sense, in the sense that, oh, we can predict what their expenditures might be, and we can ask, are they choosing the plan that is predicted to minimize costs? In neither of those senses do the vast majority of people choose the cost-minimizing plan. Typically, they're leaving hundreds or even thousands of dollars on the table by not choosing the cost-minimizing plan, and this result has been replicated across an enormous range of settings. So we know this is true for prescription drug insurance, for employer-provided health insurance, for Medigap, among many others. Now, this doesn't necessarily show that people are making a mistake, because you might say, fine, they're not choosing the lowest cost plan, but that's not the point of insurance. The point of insurance is to provide people with risk protection. So of course, they're paying a little bit more than they need to on average, but maybe they're enrolled in a plan that provides them with better coverage in the state when they really have to spend a lot. It turns out that seems not to be the case. So the graph that I'm showing you here is the graph of the Medicare Part D choice set in California. So we have 50 different plans that consumers can choose from. On the x-axis, we have the average expected total costs for these plans. Okay, so there are some plans that cost people $2,000 a year on average, some plans that cost people less than $500 a year on average. On the y-axis, we have one possible measure of the amount of risk protection that the plan provides. In this case, it's going to be the average standard deviation of costs. So the idea here is that if a plan provides really generous risk protection, it gives you more coverage when you have to spend a lot, and so the standard deviation of costs is lower. What we can see from this graph is that the vast majority of plans, do not lie on what we might call the efficient frontier with respect to average total costs and the standard deviation. In other words, for the vast majority of plans, there is some other plan that is better in both respects, that has lower costs and lower variance. So it's not as though people are just choosing, let's say, this plan in the lower right, where they're paying an enormous amount, but they're getting the best possible risk protection. Most people are choosing plans in the upper right, where there is some alternative plan that is lower cost and provides better risk protection. A similar thing, we can do a similar exercise with quality ratings, and we can show that neither risk nor quality appear to explain the choices that we observe. So This still is not definitive evidence that people are making mistakes. There might be some other aspect of plans that just aren't captured in our model that nonetheless people care about that are driving their choices. So for example, in prescription drug insurance, it might be the case that certain plans give discounts at local pharmacies not observed in our model, or something of that nature. So an alternative test of whether people are making good choices is to look for explicit evidence of choice inconsistencies. So one example of a choice inconsistency from some of my earlier work is that beneficiaries appear to value premiums more than out-of-pocket costs. In other words, what they ought to say is, look, a dollar is a dollar. I don't care if a plan saves me $100 because the premiums are lower by $100, or if it saves me $100 because it provides more generous coverage. So given the claims that I will predictably have, I would save $100 in out-of-pocket costs. If anything, the out-of-pocket cost savings should be more valuable because those will also provide some degree of risk protection. In practice, we find the opposite, that consumers are far more sensitive to variation across plans and premiums than variation across plans and out-of-pocket costs. And that is one of the big reasons that they're not choosing the cost minimizing plan. Now, another choice inconsistency that one robustly finds is that consumers don't appear to value financial plan characteristics appropriately. One very clear example of this is how much they're willing to pay to avoid deductibles. So if you choose a plan with a $1,000 deductible, the most that can possibly cost you is $1,000. But now there's clear evidence of cases where people are willing to pay more than $1,000 in premiums to avoid a $1,000 deductible. Another sort of error that's been documented is in survey evidence, we can see that consumers have incorrect beliefs. They have incorrect beliefs about their own past expenditures, about what their future expenditures are likely to be, and they have incorrect beliefs about the nature of the different plans available to them. So they will wrongly report which plans have larger networks or more generous coverage, for example. We can see that these incorrect beliefs are also correlated with their choices. So altogether, in Medicare Part D, these identifiable choice inconsistencies explain about 50% of the money being left on the table. So in other words, 50% of the money being left on the table, not only can we see that there's no other factors, observable factors that appear to rationalize it, but we have a clear mechanism for what the mistake is that explains why they're leaving money on the table. The other 50%, while they're leaving that money on the table, those plans don't appear to be better in any respect, but we can't rule out the possibility that maybe there is something else that they care about those plans. Now, a final note to make about beneficiary choices is that in a wide variety of settings in health plan choice, we find that beneficiaries are enormously inertial. 80 to 90% of beneficiaries choose the same plan that they chose in the previous year. And this is true despite the fact that they could have saved hundreds or even thousands of dollars by switching plans. Typically, when we do see that beneficiaries switch, they will switch because of large increases in premiums for existing plans, not because large savings become available from some alternative plan in their choice set. So the fact that they're so much more sensitive to changes in their existing plans is consistent with a model where this inertia is driven not by what we might call like true adjustment costs, but rather just by inattention, by the fact that, look, they're not looking every year at all the alternative plans in their choice sets and deciding if it would be cheaper. They only bother to look if their current plan becomes extremely unsuitable. Okay, so to summarize, beneficiaries are not cost minimizing. Their chosen plans don't look better on other observable dimensions. There's explicit evidence of choice inconsistencies, and there's a huge amount of inertia in choices. So before we think about some policy options, I want to ask the question, why do we care that people are making mistakes? One reason that we should care is we might think too much money is getting transferred to insurance companies. A second reason is that we might think, well, there's bad matching of people to plans. People have particular preferences about what type of plan they want to enroll in, and they end up enrolled in the wrong plans. This is also related to the idea of adverse selection. I'll say more in a moment. A third reason we might care is it might be that the benefits that insurers offer would change if consumers made better choices. Okay, so let's talk about the first reason, the idea that because consumers are making mistakes, we end up giving too much money to insurers. Firstly, it's just an immediate consequence of the fact that consumers aren't minimizing costs, that in some sense, they're paying more to insurers than they need to pay. So insurers gain from that. It's also true that not only are they paying more holding prices fixed, but the fact, especially the fact that consumers are so inertial in their choices, dramatically reduces price competition amongst insurers. In other words, if consumers were less inertial, then it would be very easy for one insurer to lower their premiums, to undercut another insurer, and to encourage people to switch plans. Because they're so inertial, that generally doesn't happen. So we can ask the question, to what the fact that consumers are so inertial contribute to consumers paying more to insurers in premiums because of the lack of price competition? And it turns out this effect is quite important. So in a study of Medicare Part D choices in New Jersey, the study found that eliminating inertia directly for fixed premiums saves $82 per year per beneficiary, but it saves $248 per year per beneficiary through increased premium competition. So this effect could be quite important. But thinking about whether insurers are really getting more money as a result of this, especially in government-regulated health insurance markets, is actually quite complicated. Because in Medicare Part D and in the Affordable Care Act, there are all of these regulations that try to restrict insurers from having too many profits. So there are risk corridors, there are medical loss ratios, there are what are called reconciliation procedures, where basically at the end of the year, the Center for Medicare and Medicaid Services will look at these plans and they'll say, okay, here is what you collected in premiums, here's what you paid out in benefits. Did you pay out too little given what you collected? And they'll take back some of their profits. So given this, to the extent that those provisions achieve their stated goal of limiting insurer profits, the effect of these kinds of mistakes that absent those regulations would increase insurer profits might be just to redistribute money from people who make mistakes to people who don't. And do we like that redistribution? Well, it's hard to say. So we might want to move on to think about some of the other consequences of mistakes. One other consequence of mistakes is that, well, it leads to welfare losses from bad matching. The simplest possible world we can imagine is a world where, let's say, every insurance plan is identical and they only vary in their premiums. In that world, yes, there could be mistakes. You're not choosing the lowest premium plan, but it doesn't really matter what plan you're actually enrolled in. But in the real world, it might matter which plan you're enrolled in. Let's say because plans vary in their amount of risk protection, consumers vary in how much they value risk protection. So what we want is the consumers who value risk protection most to enroll in the plans that provide the most generous risk protection. To the extent that people make mistakes, maybe that's not happening. Maybe that is leading to welfare losses. Now, there is actually an offsetting effect, and that offsetting effect was pointed out by Ben Handel and is called adverse selection. So adverse selection occurs whenever there are aspects of beneficiary risk which can't be incorporated into premiums. So the classic example is the adverse selection death spiral, where you have a generous health insurance plan that says, okay, we're going to have annual premiums of $10,000 a year or something like that. Now the problem is when you have annual premiums of $10,000 a year, the only people who want to choose your plan are the very, very sick people who expect to get benefits of even more than that, at least if they're being rational. So then you get even sicker people being enrolled in your plan, your costs exceed your premiums, and you have to raise the premium even more. So the next year, it's $13,000 a year. But then you get even sicker people enrolling in the plan, premiums spiral out of control, and either you don't get generous insurance plans being offered, or if they are offered, the premiums that are offered end up being too high. Now, inertia and mistakes more generally can actually help combat adverse selection. If you have inertia and mistakes, what that's going to mean is the sickest people don't necessarily do a good job of choosing the plans with the most coverage. And so that can actually improve welfare. So what Ben Handel shows in this paper is that in at least one setting of employer-provided health insurance, inertia, the presence of inertia is making consumers better off by helping to combat adverse selection when there otherwise weren't good mechanisms or mechanisms in place to do so. Now, the importance of this effect is likely lessened in the Affordable Care Act and in Medicare Part D because there are subsidies in place designed to combat adverse selection. So we would still have the welfare losses that come from mismatching, from choosing the wrong plan, but we wouldn't have the mistakes generating welfare gains via adverse selection. Now, the third reason that mistakes might matter is via their impact on the types of coverage that plans offer. Once again, this interacts in a somewhat complicated way with regulations. In Medicare Part, so what one might think would happen, I told you earlier, consumers are insufficiently sensitive to out-of-pocket costs, to the coverage that they get from insurance plans relative to premiums. So one might think that the insurers would respond to this by saying, okay, we'll offer plans that have very ungenerous coverage. Consumers won't be paying attention to that, will benefit, and consumers will just choose plans where they pay a reasonable amount of premiums but have almost no coverage. Now, they're prevented from doing that, at least in part, in Medicare Part D and the Affordable Care Act by regulations that I talked about earlier that basically say, look, you need to provide coverage that is actuarially equivalent to a standard plan. You need to pay out a certain amount of benefits. Now, whether those regulations work perfectly or whether insurers can circumvent them is a complicated issue. I have some ongoing work trying to explore that. But there's actually almost no work on what I think is potentially the most important consequence of consumer mistakes. And that is the way that consumer mistakes impact insurers' incentives to innovate and to adopt new, potentially cost-saving or quality-improving measures. So let me give you an example. There's now, I think, reasonable evidence that retail clinics act primarily as a cheaper substitute to doctor's office visits for at least some types of care, for like immunizations, for bronchitis, for that sort of thing. So given that evidence, we might think that insurers would cover retail clinics, and by doing so, they would save money. So let's imagine a world where you have either one consumer or 1,000 identical consumers, it doesn't matter, where the price for each of those consumers is $500 at a retail clinic and $1,000 at a hospital. Let's say the cost to providing identical services is $400 at the clinic and $600 at the hospital. So both the clinic and the hospital make profits. The clinic is lower cost and more efficient for society. Let's say the insurer is thinking about paying 50% of the cost. If the retail clinic is covered by that insurer, what's going to happen? Well, if the consumer goes to the retail clinic rather than the hospital, then the insurer would save $250 in the amount that they have to pay out, 50% of the price difference, and consumers would save $250 in out-of-pocket costs. That seems like a good deal, but the hospital would lose $400. They would lose their profits. So the hospital can come back and say to the insurer, look, we'll give you a $350 rebate on your costs as long as you agree not to cover retail clinics. Now, if consumers were paying attention, that should never happen. The economic reason it should never happen is called the Coase theorem, but intuitively, the idea is the insurer could say back to the hospital, there's no way we're doing that, because by covering retail clinics, we'll save $250. And if we wanted to, we can get an additional $200 from consumers. We can raise consumer premiums by $200. They'll still be happier than they were before because they're actually saving $250 in out-of-pocket costs by the fact that we're covering this retail clinic. But if consumers aren't paying attention, that can't happen. The insurer has no way to capture any of the benefits that are, in fact, accruing to consumers. And what that means is that in practice, what the insurer will do, rather than covering the retail clinic, they'll just use the threat that they might cover the retail clinic in order to negotiate a better deal with the hospital. So, okay, some money gets transferred from the hospital to insurers, but we don't get the cost-saving innovation, which would be to cover the retail clinic. This is a really critical issue because there are lots of potential cost-saving innovations in medicine, things like telemedicine, other kinds of innovations we haven't even thought of yet. And if we ask, why do we structure Medicare Part D and the Affordable Care Act the way that we do? What are some possible advantages over single payer? I think the biggest possible advantage is that you would have more incentives for innovation. If you have consumers not paying attention, then you severely blunt those incentives for innovation. As I mentioned, unfortunately, we don't really have good empirical evidence on this effect, but certainly theoretically, it is something that we can expect to happen. So this all raises the question, what can we do about this? Well, I'll consider 3 policy options. We can give people more information, we can nudge them to make active choices, we can default them into a good option if they don't make an active choice. So there's a recent position paper by Ben Handel and John Kolstad that fleshes out in a lot more detail how these different options might work. I'm going to talk a bit about some of the more general issues involved. So giving people information. We have some experiments that have tried this. One of the largest was in Medicare Part D. The researchers had a control group and a treatment group. In the treatment group, they sent them a mailing that said, here is what your costs would be to each of the alternative plans in your choice set. You could save this much by choosing this different plan. Decide for yourself if you want to switch. What they found was that switching increased from 17% to 28%. Switchers saved about $100. So on average, consumers in the treatment group saved about $100 out of the $500 that was possible if they all switched to the lowest cost plan. So I think this example raises some of the promise, but also some of the pitfalls of information interventions. There's 3 challenges. The first challenge is dealing with the logistical question of how do you get people to pay attention. So I said they could have saved $500, but in fact they only achieved about 1/5 of the possible savings. 72% of the people still just stayed in the plan that they were enrolled in. Why did that happen? Well, one major possibility is, look, they got this mailing, maybe they didn't pay attention to it. They got another letter in the mail about Medicare Part D. They're like, well, I keep getting all these random mailings about all the public programs I'm enrolled in. It usually doesn't pay for me to look closely at those, so I'm just going to throw it out. They end up not looking at it and realizing that, in fact, they could have saved a lot of money. So John Gruber and I have an ongoing experiment in Oregon among public school teachers, where we did a similar kind of experiment. We randomized all the people in the treatment group to an online tool that would help tell them, here's what your cost would be to each of the different plans in your choice set. To access the tool, what happened is people went to the website where they would make their plan choices, and there was a giant link that said, click here to use the tool that will tell you the cost to alternative plans. Now, the first year that we did this, for technical reasons, you had to create a login when you clicked on that link. Turned out about 7% of people bothered to create a login and use the tool. Okay, so it's very easy to fail in designing a website for this sort of thing. Let's put it that way. So the next year, we said, okay, well, we are going to basically make it mandatory. If you choose a plan through the website, then you are going to have to go through this tool to see what your costs are. So we're gathering results from that experiment now. A second challenge is that if you do give people information, you want to make sure that there is some mechanism in place to prevent adverse selection. So some form of subsidies to insurers or something like that to prevent the problem that can arise in, say, an employer setting if you don't have that. Third, there is a subtle question about whether you are actually giving the people the information that they need. So what this experiment did, what most experiments on information provision do, is to say, well, given your claims in the previous year, here is the plan that would be least expensive. But we might think that really, that's not the right exercise. Really, the best thing for us to do is to say, well, you should be changing your behavior in certain ways as well. For example, in prescription drug insurance, maybe what should really happen, if you really want to reduce costs, what you should do is choose a plan that provides generous coverage for generic drugs. And then you should substitute. You should consume generic drugs instead of the branded drugs that you currently consume. If we just ask what plan is cheapest given what you did the previous year, we're not going to recommend that. We're just going to say, here's the plan that is cheapest given the branded drugs. And this goes back to the retail clinic example. If we say, what plan is cheapest given what you did in the previous year, we're not going to capture the fact that, in fact, if Plan B provides coverage of retail clinics, you could have saved a lot of money by choosing Plan B and then switching to retail clinics rather than physician office visits. So we have to be really careful here to try to give people information about what is actually likely to happen to them. So that illustrates another pitfall. We could say, oh, let's assume you're going to switch to generic drugs and choose the plan that's cheaper given that. But if you're not really paying attention, you don't realize that, oh, I could save money by switching to generic drugs. We tell you to choose Plan B rather than Plan A. Again, we've given you the wrong information because, in fact, you would have been better off choosing the plan that was cheaper given that you're not going to change your behavior. So there's a lot of subtleties involved in how we design these systems. A second option that we can pursue are what are called nudges. So we can say an example of a nudge in this context is in order to combat inertia, we can try to force people to make an active choice. So this is similar to the experiment in Oregon that I told you about. We can say, look, when you go to choose your plan every year, the most extreme version is to say something like, we'll fine you if you don't actively send back a mailing making a choice. So you can't just not pay attention and be defaulted into a plan. Now, in our analysis of Medicare Part D choices, we find that had inertial consumers actively chosen, but done only as well as switchers, in fact, they wouldn't have saved that much. They would have realized only about 20% of the possible savings. And that's because just the fact that they're making an active choice doesn't mean that they can figure out which plan is lowest cost for them. Now, if you look in data, you'll see that the people who do switch tend to save a lot of money. So just looking at the switchers, you'll say, oh, the average switcher saves $1,000 a year or something like that. But that doesn't mean that the average person would save $1,000 a year if they switch. The issue is that the switchers tend to be people whose existing plan just became really, really bad. And that's why they switch. So they save a lot of money by switching, but everyone else whose plan was just okay for them wouldn't necessarily save that much if they switch. So we have to be careful about nudges too. A third option is better defaults. One might say if we're worried that people aren't choosing the lowest cost plan, why not just default them into whichever plan is lowest cost? One worry here is the same issue that arises in the information intervention. Lowest cost given what? Lowest cost given their prior year claims, lowest cost given some model of how they could substitute to save even more. That's one important problem. A second problem is that if you default everyone into the lowest cost plan, there's a lot of room for gaming by insurers. There's a lot of room for them to say, I can make enormous profits if I can find some way to make a plan that, according to whatever model CMS uses, is actually going to be lowest cost, but in fact is going to provide coverage that really is not very generous, just manages to get around whatever model CMS uses. Okay, so what are the upshots of our discussion so far? If you help people choose better, you can probably reduce premiums. You have to be careful about adverse selection. You have to be careful about how you model cost savings and substitution. And also, you have to be careful about what role the regulators are going to play and whether you're making their job too difficult. So I think there are lots of gains that are possible here, but it's not so easy to design a policy that will help people to choose better. So let's move on then, in the last couple of minutes, to talk about mistakes by providers. What I'm showing you here is a very famous map in health economics. This map is showing you Medicare spending by region. There's enormous variation in Medicare spending by region, and the stylized fact is the regions that spend more, even when we condition on patient health and patient risk, don't appear to have better outcomes. So this is suggestive of what is called productive inefficiency. Another word for that is flat of the curve medicine. We might think that, look, if McAllen, Texas, which spends twice as much as El Paso, Texas, would cut spending by half, they're just doing lots and lots of extra stuff that's completely wasteful. They could get the same outcomes at much lower cost. Another potential form of inefficiency is what we might call allocative inefficiency. The problem isn't that we're spending too much, but the question is, how are we spending any given dollar? If we take $7,000 in spending, are we using that $7,000 wisely or poorly? And what I want to talk about today is a recent paper where we try to figure out which of these problems is more important. Is the problem that in some cases we're doing too much, or is the problem that we're actually doing the wrong things with the money available? So in this paper, we're looking specifically in the context of CT scans for pulmonary embolism. A pulmonary embolism is a blood clot in your lungs. And we ask the question first, is the observed variation that we see due to patient variation or physician behavior? In other words, is there clear evidence that in fact, for identical patients, some physicians are testing a lot more and therefore arguably doing too much? And second, we can ask whether physicians are weighting patient characteristics appropriately. In other words, so physicians trying to decide which patients to test, they see lots of things about those patients. They see whether they have a history of pulmonary vascular disease. They see whether they're obese, 50 other things. We can ask whether when deciding which patients to test, they are weighting those correctly. Okay, how much time do I have, by the way? Okay, thanks. Okay. Okay, excellent. Okay. So when we do this exercise then, one thing, so the first question that we want to solve is how can we distinguish between physicians who are testing more for a given patient population versus testing more because their patient population is more suitable for being tested. And the way that we can do this is as follows. First, let's look at the top graph. The top graph is an example which parallels one interpretation of the colorful map I showed you. The top graph is an example where we say, look, the reason for variation across physicians, the reason that some physicians are testing more than others, that's what the x-axis shows, the number of patients being tested, is that those physicians have a lower threshold for whether they want to test a patient. So imagine there are some physicians who will test any patient with a probability of being tested, a probability of a positive test that exceeds 5%. There are other physicians that will test any patient with a probability of a positive test that exceeds 3%. What the graph here is showing is the PE risk distribution in the population. So we are saying there are some physicians that will test every patient with a probability of a positive test between tau A and 1 on the y-axis. Then there's other physicians who test more for the same patient population. They will test any patients with a probability of a positive test between tau B and 1. The result of that is that you'll see that the physicians with a lower threshold test more. They will test at TB on the x-axis rather than TA, and you will see that the physicians who test more have a lower average probability of a positive test. Okay, so the point is, if what is going on is that every physician sees the same patient population, some physicians just test more. They go further down the distribution of risk. They test patients who are a little bit more unsuitable. Then we will see that the physicians who test more have a lower likelihood of a positive test. Now there's another possibility. Another possibility is that the physicians who test more do so not because they would tend to test more for any given patient population, but because their patient population is more suitable. So in panel B, we see an example where two physicians have the same testing threshold on the y-axis. Both physicians, let's say, test every patient who has a probability of a positive test greater than 4%. What we see, though, is that physician B has a patient population which is more predisposed to have pulmonary embolisms. What we're going to see in that case is that physician B, who tests more, is going to have a greater likelihood of a positive test conditional on testing. Okay? So in both cases, we observe physician B tests more than physician A. If they test more because they have a lower threshold, then we expect that the likelihood of a positive test is smaller. If they test more, because their patient population is more likely ex ante to have pulmonary embolisms, then we expect that the likelihood of a positive test, conditional on testing, is bigger. So what do we actually observe in the data? Well, what we observe in the data is fairly striking. We observe that the physicians who test more, as the fraction of patients tested by doctor increases, the test yield declines dramatically. So for physicians who test about 8% of their patients, 6% of tested patients test positive. For physicians who test only 1 to 2% of their patients, 7 to 9% of their patients test positive. When we make various calibration assumptions about what's the value of finding a positive test, what's the cost of the test, this is going to imply that a large number of physicians are testing too much. They're testing patients even though, given the likelihood of a positive test, the costs actually exceed the benefits. So there's going to be evidence of productive inefficiency. In the paper, we're not just using this aggregate data, we're looking at Medicare claims data, we're looking physician by physician. And we can see that at the physician level, physicians are on the margin testing. We can locate specific patients for whom we can say that patient has a really low predicted probability of a positive test. And therefore, given the cost and benefits of testing, you are probably getting more costs than you are benefits. Also, in this setting, we can look for evidence of misweighting. The simplest test for misweighting is to compare, for patients with and without a given characteristic, how does it impact the fraction of patients tested, and how does it impact the likelihood of a positive test. So take the first example here of prostate cancer versus not having prostate cancer. We see that patients with and without prostate cancer are about equally likely to be tested. But nonetheless, patients with prostate cancer are much more likely to test positive, conditional on being tested. There's several other factors where physicians appear to move in the right direction, but there's a question of whether they move far enough in that direction. So physicians are more likely to test patients who have a history of a pulmonary embolism, a history of deep vein thrombosis, or a prior hospital visit. But those factors predict extremely large changes in the likelihood of a positive test. And our model allows us to say, should physicians be even more sensitive to these factors? There are some factors for which we actually observe physicians moving what seems to be in the wrong direction. So physicians are more likely to test patients with chronic obstructive pulmonary disease, but in fact, patients with that observable are less likely to test positive, conditional on being tested. Now, there's an issue here. This table is just looking at these factors one at a time. What our model allows us to do is to say, conditional on all of the other factors. Does this pattern still hold true? Do we still see that conditional on all of the other factors, a given factor predicts what pattern of test yields does it predict? How does it impact the likelihood of a positive test? And what pattern of testing does it predict? And what we find is evidence of systematic misweighting. We find that there are a large number of factors which physicians underweight in deciding whether to test, where physicians should be paying more attention to those factors, and we find that there's also a large number of factors that physicians overweight. So then we can ask, what is the relative importance of underweighting and overweighting? Given our calibration assumptions, so first let's talk about the importance of productive inefficiency, okay? The problem that some physicians are testing too much. So given our calibration assumptions, our model suggests that with no overtesting, welfare would increase by about 60%. So this is the analog of looking at the colorful map that I showed you earlier and saying, oh, what if McAllen, Texas looked more like El Paso, Texas in their spending? There's flat of the curve medicine. Some physicians are doing too much. How much would we save? And this is saying there are enormous savings possible from reducing productive inefficiency, from the fact that a huge number, there's a lot of testing for pulmonary embolism that is really unlikely to detect anything. Okay? Now, this is not a surprising result, and the reason it's not surprising is because we picked this setting precisely because there is anecdotal and other evidence of overtesting in this setting. So the American College of Radiology targeted pulmonary embolism as one of 5 procedures for which they think there should be a massive reduction in use, because they think there's a lot of CT scans being done that just don't detect anything and predictably didn't detect anything. Okay? So this vindicated what essentially all of the physicians we talked to told us. But we also found another more surprising result. We found that with no misweighting, welfare increases by 300%. So in fact, even though we selected this setting precisely because we thought there would be a lot of productive inefficiency, a lot of overtesting, what we found is that the predominant factor in this case is the misweighting, is the fact that physicians are not selecting which patients to test in a way which maximizes the likelihood of a positive test. So in fact, they're missing a lot of pulmonary embolisms. So it is simultaneously true that they are testing too much, because there are some patients who are really unlikely to have a pulmonary embolism who get tested, and in some ways they're testing too little because there are other patients who in fact should be tested, but they're not testing because they're not in some way looking carefully enough at the characteristics of those patients. So yes, there's lots of productive inefficiency, but at least in this one setting where we can compare the productive inefficiency to the allocative inefficiency, we find that whether we're spending the given dollars correctly is actually more important. So what can we do about that? Well, there's a couple of possibilities that are being explored in ongoing work. One thing that might be going wrong is you might think, well, physicians just need to adhere to existing guidelines. And if they adhered to existing guidelines, they would test the right patients. Now, that's not necessarily true. Another possibility is that the existing guidelines were misleading for some reason. And there are various statistical reasons to think that that might be the case. That in fact, the existing guidelines might be leading doctors to do the wrong things in certain circumstances, and what we actually need are better guidelines. Now, it might be the case that even if we had better guidelines, what we don't want to go too far in that dimension. In other words, no matter what observables we include in our guidelines, there's this point that physicians might observe something that's not in our model. And they're also using other information not in the guidelines. So we don't necessarily want to say, oh, look, we have this model. We are going to, let's say, force physicians to strictly adhere to that guideline, and that's what they're going to do. Although in ongoing work, we can at least test whether that would lead to better patient outcomes. If we force physicians to adhere to guidelines and throw out all of the other information they have. I think there's a variety of reasons we actually don't want to do that as a policy, but as a conceptual exercise, it's helpful to understand what would happen. Would that have certain benefits? And are there other policies that could also achieve those benefits? Another policy option is to warn doctors if their behavior departs from the model recommendation. So this is one way of trying to make the fact that they're departing from the guidelines more salient, one way of trying to encourage adherence to guidelines while not necessarily forcing them or incentivizing them to adhere to guidelines. Okay, now a final problem that might be occurring is we don't necessarily know from our existing data whether the problem is that doctors see certain variables and are weighting them inappropriately, or if the problem is just that doctors never see those variables. We know that data exists in the world. We know that it's in the Medicare data, but it might be that as you switch between providers, when you switch from one provider to another, you just don't see that this patient, actually has a history of pulmonary vascular disease. And therefore, if I had known that, sure, I would have given them a CT scan for pulmonary embolism, but given the data I had no way to know that. Okay, so it might be, and future work is also investigating this, it might be the case that the problem is just that we need more information sharing. We need doctors to be aware of the past history of their patients. Okay, so I will wrap up there. Our takeaway then is there does seem to be clear evidence of mistakes both by consumers in their health plan choices and by providers in their testing behavior. There are policies that seem like they would have some efficacy in combating mistakes, but all of these policies have a lot of subtlety and complexity, and much more research is needed to understand some of the potential pitfalls of these policies. Okay, thank you.
Hi, Paul Howard, Manhattan Institute. Jason, terrific presentation. Just a couple of questions. How do the search costs for Medicare Part D or ACA compare to other insurance models? My sense is thinking about not health insurance, but homeowners insurance or car insurance. Those are similarly sticky markets. Consumers could save by switching, but oftentimes they don't save by switching unless, as you said, there's a big bump in premium. Can you talk about comparisons there to those other markets, what we could learn or not learn from those markets? And then finally, how do physicians behave if they see their testing rates compared to other physicians in their practices or networks?
Okay, so two good questions. So first of all, on the switching cost question, so there's a couple of things to say about that. One thing is, so there are a couple of reasons why you might think, or rather the search cost question, that search costs are especially high in the context of health insurance, especially in programs like Medicare Part D. One reason is that you just have a large number of choices that consumers are confronted with in a centralized exchange. Now, it's interesting when you compare it to the case of something like car insurance, where typically it's the case that it's less clear what your options are. Like, you don't just get a mailing that says, here's the 5 car insurance plans you can choose from. So what'll happen is sophisticated consumers will use a website, and that website will say, here's 5 different insurers you could choose from. Now click on each one and you can try to figure out what's going on. So on the one hand, there's a sense in which your search costs are even higher for car insurance because you don't even know what your options are. But I think realistically, the main takeaway is that your search costs are likely to be extremely high in both cases if what you want to do is figure out, here is what your costs are going to be for these different options. And I think it's perfectly rational for a large number of people not to bother paying those search costs, to say, look, it would cost me hundreds of dollars or even thousands of dollars worth of time to really figure out what my cost would be to these alternative plans. And that suggests that there might be potentially large welfare gains from providing information, even if it doesn't lead people to choose. So even if people ended up making the same choices they ultimately made, just because it reduced those search costs. So your other question was about how physicians change their behavior if they observe what other physicians do. And so I'm aware of one study to that effect which showed that there was a significant but small impact. So I think the answer is yes, there is potentially some role for saying if we give physicians information about what their peers do, that can impact their behavior, but it's not the kind of thing where if you talk about the welfare losses that I documented in my study, it's going to eliminate any substantial fraction of those. Yep.
It's just a very quick question. Is the legal factor part of the physician behaviors as well? There's this whole cloud of lawsuits and the fear of one that may, in many places or in many occasions, make the decision of the provider.
So I think that's more likely to be relevant to what I called productive inefficiency than what I called allocative inefficiency. So I said there's these two kinds of mistakes you see in the data. One is that there's like flat of the curve medicine where some physicians are doing tests where they're really unlikely to find a pulmonary embolism. And in that case, one reason they might do that is in response to malpractice concerns. But then there's this other sort of error where they're just testing the wrong patients, given the patient history. And I think, well, you know, if what they were concerned about is something like malpractice, they would really, really want to avoid the failure to test these patients who should be tested, okay? So I think that malpractice concerns are unlikely to be responsible for the observed misweighting, which was in fact in our model, the more important factor. They could be part of the story when it comes to why physicians are testing too much. Now, there's actually a large literature on this in economics, and to summarize an enormous and complex topic, I would say there is evidence that malpractice matters, that it explains some percentage of the observed variation in spending, but that it's marginal. It doesn't explain why you see all those different colors in the map that I showed you. It doesn't explain why healthcare costs have grown over time.
Hey there. So I was wondering about I thought your model for consumer behavior was very compelling when it came to the fact that consumers don't minimize costs and they make inconsistent choices. I wanted to see how that would play out if the purchaser was a more rational actor, like a benefits office in a large organization.
So that is an interesting question. So first of all, I don't know of any papers offhand that explicitly look at this question of, if you have a proxy who is choosing your plan for you, do they do a better job? Now, in most cases, so I guess that is likely to be similar to the case I discussed, where the choices are made sort of mechanically by a model. So I discussed the one policy option. We could just default people into the lowest cost plan. And if you have, for example, a benefits officer making a choice for you, I mean, one possibility is they could invest the time that you're not investing. So for every beneficiary, they could spend 10 hours thinking about that beneficiary's history and making an individualized choice given everything they know. And that might do better. That would involve a lot of investment of time. An alternative is for the benefits officer to make a choice using some more mechanical procedure, and then it would run into the same kinds of issues that I talked about for those sorts of policies. But I definitely think, I don't mean to be dismissive of this idea. There's definitely potential room for a policy where we would say, look, Fiona Scott Morton has proposed this at least to say, let's have pharmacists, for example, play more of a role in Medicare Part D choices. Let's pay pharmacists to make a recommendation to consumers, and then given everything they know about plans, because it's easier for them to do that than for every consumer to learn de novo what the characteristics of the plans are, and for people to make a choice based on that.
Can I ask one more follow-up question? Just a quick extension of that. So my fundamental question is, if a large percentage of healthcare purchasers are companies and they do have a rational incentive to minimize costs, why do we see some of the perverse outcomes that are explained by your model here being expanded to the general population? Does that make sense?
I'm not sure so you're saying so a lot of the results that I talked about, first of all, were in Medicare Part D, where that's all individuals choosing. But you're saying it's common in our healthcare system that employers are in various ways restricting the choice sets that are available to consumers. Now, I would say the most common thing now is not that, employers choose one plan for everyone. Employers will still give consumers a menu of options. And then there is the question of how do consumers choose from among that menu. It's challenging to ask the same kind of conceptual question about the decisions that employers are making, because often we don't observe the menu of options that the employer is facing, because, for example, the premiums would be negotiated on a case-by-case basis with each of the insurers. So one answer is, honestly, we just don't know whether employers do a better job of choosing from a menu of options than consumers do. But a further point is, employers are facing a different sort of problem. They're not facing the problem of, given a particular consumer's history, given a particular consumer's projected future costs, what's likely to be best for them. They're faced with the problem of, how do I circumscribe the choice set of the employees in my plan? And even if they do a good job of solving that problem, there's the next problem. You're still faced with the question of either they've imposed a single plan on everyone, which might not be suitable, or beneficiaries themselves aren't making good choices.
Thank you.
Hi, Rebecca Lundstrath, UT Medical School. Thank you very much. Question for you regarding consumer behavior. It dawns on me, has any research been done regarding risk tolerance? In the equation risk has in choosing or not choosing to switch plans? Because that seems like a missing variable to me.
Yeah, so that's included. So most of the studies that I talked about in various ways are going to try to measure risk and to include it in the model. It turns out in Medicare Part D specifically, the variation in risk has relatively little explanatory power in explaining the choices that people make. Now, that might be because, well, the whole problem is so complicated that people can't even figure out which plans provide better risk protection. So they know there are certain characteristics, like whether a plan has donut hole coverage or something like that. So consumers are more likely to choose plans with these desirable nominal characteristics, but conditional on those characteristics, some consumers get far more risk protection from them than others, and we find that consumers aren't really sensitive in the way that you would expect, where the consumers who get more risk protection are far more likely to choose the plans that have those characteristics. So what you see, at least in Part D, is that people are just relatively insensitive to risk. Now, in other settings of health plan choice where maybe there is more risk out there, because with a prescription drug plan in Part D, there's catastrophic coverage, there's various things that limit the total risk that people face. That might not be the case in employer-provided health insurance. You might be exposed to more risk. And I would say there's some evidence in those settings that risk aversion is more important, and then it's typically explicitly incorporated into the model. So rather than just saying, are people choosing the plan that minimizes costs, we would say, are people choosing the plan that maximizes welfare, where welfare is a function of risk protection minus costs.
Hi, David Newberger. I have a question. Has there been any work done on the impact of the mandate on consumers?
Yeah, so that's a very good question. So the mandate is one of these policies that is designed to combat adverse selection. So I mentioned this in the context of saying, look, if we help people choose better, we might worsen adverse selection, the tendency of sicker people to choose plans that have more coverage, even though that can't be priced into their premiums. A mandate is basically a way of saying, well, if we force everyone to choose coverage, at least the healthiest people can't opt out. It combats adverse selection on that margin. So the best papers, so there are several papers that I'm aware of on this. One of them is by Amanda Kowalski, looking explicitly at the mandate in the Affordable Care Act and how that impacts welfare in that market. And she finds that the mandate is definitely helping. It's helping to combat adverse selection, and that the market would be worse if the mandate were not present, because you would get much higher prices for the more generous plans that would price out people who benefit from choosing those plans.
Hi, thank you for this thought-provoking work that you're sharing. I'm Laura Peterson. I'm a physician, health services, health policy researcher at Baylor and the Houston VA. So you said that you were only aware of one paper about feeding information back to physicians to change physician behavior, but there's a whole literature. Yeah. So there's actually a Cochrane systematic review combining all the literature about audit and feedback. So I really encourage you to look at that health services.
I didn't quite mean that. What I meant was I was aware of one paper where they took physicians and they showed them, here are their testing rates. How does that impact their behavior if they see the testing rates of other physicians? But I agree that there's enormous literature.
There's a huge literature doing exactly that. So I would just encourage you to look at that literature, because there's also literature about feeding information back to patients.
I would say more broadly how this relates to the paper that I'm talking about. So I agree with you that this more general question of misweighting and whether physicians have appropriate information, that is like, so one could say the question economists typically ask is the question of why is there variation across regions in their spending, and the question that health services researchers typically ask is precisely the question that I'm talking about there, whether physicians are appropriately weighting factors, where do physicians get information when they make their decisions. And what I'm trying to suggest is that economists and policymakers who are concerned with the bigger picture efficiency of our healthcare system should really be more focused on these questions that are typically asked by people trying to analyze optimal physician behavior. That in fact it's a big picture inefficiency of our healthcare system that you don't have physicians appropriately weighting these characteristics for a variety of reasons, one of which might be what information they have. But I agree with you. Yeah.
And then the next question I have for you is, it seems like you've defined, when you're talking about consumer behavior in choosing plans, it seems like you've really narrowly defined what you call choosing better as being a matter of how much they pay. But I just want to encourage you to think about, people might have inertia because they really like their current doctor, their current network. They really value knowing the claim forms that they have to fill out. And so if you told me that I could save $100 by switching, even though an economist would say that I should save $100, I might value those other things much more greatly. And I think that was kind of missing in what you were defining as, choosing better.
Yeah. So to the extent that those were missing, that was in the interest of time, not because they've been completely overlooked in the current literature. So among other facts, so first of all, in the setting of Medicare Part D, which is prescription drug insurance, there's less of a concern about this issue of physician networks. But I agree that that is absolutely first order when it comes to health insurance more generally. And typically, the models assessing whether consumers are making mistakes, often they'll make the somewhat extreme assumption in the other direction, that in fact, you can't possibly make a mistake unless we won't count cost savings at all if you have to give up your current physician. So we'll say you have infinite value, and we'll only ask, are there cost savings for plans that have weekly better networks? So often on the side of being conservative in that respect. When it comes to inertia, I think one important question in the academic literature, and several papers are devoted to exactly the question you asked, does inertia represent what's called an adjustment cost, which is, in other words, what you said. It's something where it's like if I switch to a different plan, there's paperwork involved, it's actually a real cost that I have to pay. Or does it just represent inattention? And I mentioned offhand one way that one could try to distinguish those, which is if I am much more sensitive to changes in the costs of my existing plan than I am to cost savings from alternative plans, that's one piece of evidence in favor of the inattention model rather than the adjustment cost model. Because if I were otherwise perfectly rational and I were just like, well, I have to pay a $500 adjustment cost whenever I switch plans because I have to do a bunch more paperwork, then it should say, it doesn't matter to me whether my plan costs $500 more because my premiums just went up, or that other plan is $500 cheaper because premiums went down. But in fact, you see a big asymmetry in that. You see inattention to the fact that every other plan became $500 cheaper, but a lot of attention to the fact that my plan became $500 more expensive. And that's some evidence in favor of the inattention model, but I agree with you, that's an absolutely central issue in the question of how do we normatively evaluate whether consumers would be better off if they weren't inertial.
Well, thank you very much. Thank you, Dr. Abaluck, for a terrific talk. I'm going to be curious to find out if anyone sort of goes home and checks their health plan choices, this fall for this year, and sort of see if they let us know if you decided to switch based on what you saw today. By the way, I forgot to mention, if any of you are tweeters, we do have a hashtag Baker. It's in the program, Baker NHC. So I won't be tweeting during the conference, but I'll go check what people said afterwards. Oh, thank you. So we're ready to move on to our next speaker, Dr. Limor Daphne, who is the Herman Smith Research Professor in Hospital and Health Services and Director of Health Enterprise Management at Kellogg School of Management. I had to bring this up here so I could get that title appropriate. She's also the former Deputy Director for Healthcare and Antitrust at the Bureau of Economics at the FTC. But that's the official stuff. The unofficial stuff, this is a first for this conference. Limor actually, her parents are here. Dr. Daphne is actually originally from Houston, so terrific and welcome to you. The thing that you have to realize about Dr. Daphne's research, though, she has been influencing the research on antitrust for many years before what's going on now. So you're starting to see stuff in the Wall Street Journal now and the New York Times about large mergers between hospitals and lately between health insurance companies. Years ago, she has demonstrated in her research substantial increases in prices that can occur after hospital mergers, and she's also been able to demonstrate in a different paper the enormous enormous amount of what economists call rents, but the amount that, that health insurers are able to extract from large corporations when those corporations are earning higher profits, simply because they are very large and they have a lot of market power. So I'm just going to get out of the way and let her talk about this.
Thank you, Vivian, very much for that introduction. It is indeed a special day for me to be here in Houston, to have spent last night in my childhood bedroom, to have my father, Dr. Nahum Daphne, and my mother, Dita Daphne, in the audience. My dad has been faculty for 40 years at UT Medical School, and I believe we have some family friends at their table as well, and I think that they saw me in my 5th grade play, and I'm just hoping today is better. So I'm here to talk about competition in healthcare markets, what antitrust enforcers do and don't do, and I want to start out by explaining why I think it is such an important subject for us to be discussing. Okay, the U.S. relies incredibly heavily on private markets in order to deliver and ensure healthcare, and we had a choice. We had a choice with the Affordable Care Act. We could have decided to shift toward a more public provision system, more public insurance, more public providers, could have gone all the way to single payer, but we didn't, right? We said, you know what, we believe in buttressing the system that we currently have. We believe that markets will deliver us the most efficient outcomes, the highest quality for the lowest cost. But if you go back to your introductory economic textbooks, in order for markets to work, you really need robust competition. And then if you look at those list of requirements for competitive markets, in there are many small players. But what in fact we're seeing all over healthcare is an aggregation, a consolidation of players. So my goal for today is to give you a lay of the land. What are the facts about consolidation? And then what do the enforcers of competition policy, that is the antitrust enforcement agencies, actually do about it, and what don't they do, and then maybe what might fill in the vacuum. So you can see I have a very ambitious agenda for our 40 minutes. So we'll start with the facts. What you do with them after is up to you. Okay, so we're a mixed audience. I want to make sure we're all on the same page. And when you talk about mergers, M&A, mergers and acquisition, there's a lot of lingo that goes with it. So I'm going to just lay it out very simply and give an example from the healthcare setting, which would be the vertical chain of production for orthopedic surgery. And all of the labels that come attached to different healthcare transactions originate in the value or vertical chain of production. So here I've put up a very simplistic version where you first have your primary care physician, your PCP, referring you to an orthopedic surgeon who then, if necessary, performs a procedure in a facility and then sends you on your way to rehab. Each rectangle in that diagram there represents an industry. Okay. And therefore, multiple players, we call them, using the terminology from game theory, multiple players in the same industry that merge, we would call that a horizontal merger. Okay? And that's the reason why it's exactly the same level. And if you see a merger up or down the value chain of production, we would call that a vertical merger or vertical integration. And this is where it comes from. So for example, if the orthopedic surgeon decided to take an ownership interest in or open her own facility, that would be an example of vertical integration. Okay? And there are a lot of differences in terms of how authorities look at these things, and there are different motives. So I want to walk through some of them. Those are the definitions I just gave you, and I will say that the real world, of course, isn't so black and white. Things aren't necessarily just horizontal or just vertical. We also have a word, lateral, that can be used for everything else. I tend to use horizontal and non-horizontal. And let me give you an example. Now, one of the phenomena that has gotten a lot of attention, and maybe we'll discuss it in the Q&A, is the mergers between physicians and hospitals. So you could picture that, and it is commonly called vertical integration. Why is that? It's because the physician merges with the hospital, and that is up and down the chain of production. The physician is the source of referrals to the hospital. So you could call that vertical integration, and many papers do. And And it has an element, certainly, of vertical integration, but many times the hospital is acquiring multiple physicians at once, taking an ownership interest in their practice and in the same specialty. So it could have a horizontal effect as well as a vertical effect. And that is important because when you look at the outcomes of these transactions, you want to make sure you know what exactly it is you're studying. Okay, so why would you merge in the first place? I'm going to start with the motives for horizontal integration, that is, same industry, okay? And the example that I think is really straightforward to understand is why you might move from being a solo practitioner to being a group physician practice. And the first thing I have up there is potentially you want to reduce your cost or improve your quality. And examples of that abound. You might have one receptionist, one person who manages your billing, one physician's assistant that could be leveraged across multiple providers and enable you to scale up, deliver better quality service, somebody answering the phones, responding to patients. It's pretty easy to see how there could be some economies of scale. Now, there's a question in every industry, at what point do you then turn over to diseconomies of scale? But in many cases, there's going to be some range over which it is more efficient to be more sizable. Okay? There's to some degree economies of scale in purchasing, but increasingly in healthcare, as everyone belongs to a group purchasing organization or to other collaboratives for purchasing, that is less of an issue than it was. But nevertheless, you'll still see hospital systems say, we're going to merge, we're going to get a better deal on our implants, and so forth. So there's a little bit of that. Then there's that other piece of why you might merge, which is raising price. And being a positive person, I'm going to talk about the good reasons that you might merge and seek to raise price and not diminish welfare in the process. And then I'll talk to you about what the antitrust enforcers are worried about. So the good reasons could be that as a result of your combination, even in the same industry, you're going to be able to offer a superior product to patients who will then they'll value it more, they'll be willing to pay more, and you'll be able to extract a higher price from the insurer. That is value in healthcare like it is in any other sector. So the example I think of is in Chicago, where I now reside, where the weather is infinitely worse in my view. There's a pediatric practice downtown that many of us favor, and it's affiliated with the university. They have a number of pediatricians, so they've got size, which means that they have weekend walk-in hours. There's always somebody to round on the babies and the newborns, and then they have somebody who specializes in sleep. And if you have an issue with growth, there's somebody who focuses on that, somebody else who might deal with learning issues, all in the same practice. And that creates value, that availability and the different subspecialization even within this primary care industry that enables them, I know, to extract higher prices from our insurers and to exclude some insurers, and that is value creating. What would be not value creating? Well, it would be saying, you know what, I'm going to buy the only other pediatric practice in town, and then I'm going to tell you what our price is because the kids don't have anywhere else to go. Okay. So there's one thing to create value and enable yourself to capture higher price from it, and another thing to eat up your rivals and through diminished competition be able to charge a higher price because there are no alternatives. And that's what we'd call value transferring, or frankly could be value destroying, depending on whether people have less access to services that they value. All right, that was just my warm-up. Now I want to talk to you about vertical integration. Economists get very, very excited about vertical integration, and that's because it's a little bit more complicated, but there are some similar themes. The example I'm going to use, at least for the first two motives for why organizations would integrate up and down the vertical chain of production, will be pharmaceutical companies who traditionally, less and less so, have done research and development on their drugs, and they've also integrated into doing the marketing and sales for their drugs. So why would you necessarily have both of these functions in the same organization? I'll start with the obvious. Well, there are some product improvements that arise from the constant chain of communication. For example, the R&D people could have developed some product, and then they go to the salespeople and say, we have this in the pipeline, it's going to be fantastic, it's a little subcutaneous shot patients give. and then the marketing people freeze up. They go, they talk to the physicians and their patients, and they come back and they say, that is just a non-starter. You think it's not a big deal, but they have to be trained and have their syringes and then have disposal of it. In this population, that's not going to go. And then, of course, the R&D people go back and try to come up with some alternative delivery mechanism. And this is a simplified example, but the synergies between sales and R&D are very real in a variety of industries. So that's an obvious example. You might also not want to share information across some independent company that could do marketing for drugs if you're concerned about leakage to rivals. Okay. Less obvious, warm up over. The less obvious has to do with what I would call a relationship-specific investment that is enabled through being in the same firm and sometimes cannot happen if you're in different firms. In the example that I'm giving now, suppose that you were a company, you're developing drugs, and you figure you will just hire a large marketing and sales team when you launch a drug. You don't want to have them on duty detailing all the time. You just want it on launch. If you're developing a new statin, treat cholesterol, and that team takes that drug and goes out and tries to convince physicians to buy it, they might say, this is a fantastic drug. They might be less willing to say, and so much better than this other drug that you could be prescribing to your patients, because they might be selling that other drug next year. Right? So why make a relationship-specific, sunk, irreversible investment in something when it's not a long-term relationship, right? So this is one of the reasons that you either write really long-term contracts or you just swallow the company entirely and say, in order for us to make investments in this relationship, we're going to have to be exclusive, or at least we're going to have to be under common ownership. And the last example is really best illustrated by video. So I'm going to do that, but I'll give you a very simplified version of this, which is by integrating up or down the value chain, you might be able to benefit from decisions that are made at some point in the value chain. So if I am the manufacturer of peanut butter and I make truly fantastic, amazing peanut butter, when you go to the supermarket to pick up that peanut butter, you're also going to pick up some. And am I going to benefit from that? Not unless I buy the jelly manufacturer, right? And then perhaps I actually co-brand and make it the jelly that really goes with the fantastic peanut butter. And that's the idea. It's what a business person would just call a synergy. But it's as a result of combining different parts of the value chain. But I really don't think I could do it as well as they can in 30 Rock. So let me see. Let me see if this is going to play for me. Ooh. Well, it might not. Sorry, guys. Another time. Okay. So we're talking about the facts here. So those were the motives. What are the facts? Well, he's going to fix the video? Oh.
The hearings on the Cabletown NBC deal are underway, and the company has entrusted me to be their front man.
Hey, will you ask Congress where they put the USA Network? I've been trying to find Monk for like 3 months.
The only thing I will be discussing with the House Subcommittee on Baseball, Quiz Shows, Terrorism, and Media is vertical integration.
What's vertical integration?
Imagine that your favorite corn chip manufacturer also owned the #1 diarrhea medication.
That'd be great, because then they could put a little sample of the medicine in each bag.
Keep thinking.
Except then they might be tempted to make the corn chips give you
vertical integration.
Wow, that should not be allowed to happen.
But it's my job to make sure that it does happen.
Nothing could make a professor more happy than when somebody discusses critical merger topics on popular TV. All right, so you're not going to forget that, I think. Let's talk about some of the facts, what's happening in the healthcare sectors horizontally and vertically, and now that we've got a sense of what the motives are for integration. This graph here has the blue bars represent the number of hospital transactions. It's just for general acute care hospitals. So you might see in the press higher numbers reported. This has been scrubbed by my team to reflect just general acute care hospitals because that's what I use in my research. And the main point here is just that the number of transactions has really picked up since the Affordable Care Act. So you've been hearing a lot about hospital mergers. If we had the data and cleaned up further, you would see that it's increasing still. There are a lot of hospital deals going on. What else is happening? Well, some of them are system-to-system mergers, but some of them continue to be acquisitions of independent hospitals. The red line here shows you the number of independent hospitals in the United States, how it's changing over time, and you can see a steady decline to below 2,000. Now, that might surprise some of us to realize that of the slightly less than 5,000 general acute care hospitals, that there's still about 2,000 independents, but that's in fact the case. And another phenomenon that is of interest, and certainly happening in Texas, is represented by this green line here, which is the number of hospitals belonging to a system where there are 5 or more hospitals in that system in the same state. Okay. There's certainly cross-state systems, but systems inside states are growing, and I might have a chance, I think, in this presentation to talk a little bit about what the implications of that are. Now, I don't want you to think that I'm only focusing on the provider consolidation and the ramifications of that. As Dr. Ho mentioned, I also do research on insurance consolidation, and local insurance markets have become more consolidated as well. A very common measure used to capture competition in industry is the Hirschman-Herfindahl Index, the HHI. Okay? That is the sum of squared market shares. It ranges from 0 to 10,000, with 10 being a monopoly. Okay? And you can loosely think of it as 10,000 divided by the number of players if they are equally sized. So 2,500 would mean 4 equally sized players in a marketplace. And the Department of Justice and the Federal Trade Commission can consider anything that is 2,500 or above to be very highly concentrated. And the point is that the majority of U.S. health insurance markets as defined by metropolitan statistical area would be considered highly concentrated. More than half of metro areas have a single insurer with 50% or greater market share. Also a very, very impressive statistic. We're seeing increases in concentration of the insurers that are providing plans to Medicare enrollees through the Medicare Advantage program. And I've just noted here, I wish we had more time to talk about the health insurance exchanges. We don't. They might shake things up, but it is still too early to tell. Okay, I put this together recently. I had the opportunity to talk to some senators about the health insurance mergers that are pending, as many of you are aware. And it actually was quite a lot of work to get my researchers to figure out how to even build this chart, because the data is so poor, and in particular for the Blue Cross and Blue Shield affiliates, where there are 36, I believe, independent affiliates, it is really hard to figure out how many lives are insured, and just commercial lives under 65, so we get the Medicare out of there. These are our best estimates. In blue are all the Blue Cross and Blue Shield affiliates collectively across the nation, except for in a few areas they don't compete. So for competition purposes, we consider them one insurer. The hash mark blue represents the for-profit blues. These are all consolidated under the parent company Anthem, which you may have been hearing in the press has proposed to merge with Cigna, another for-profit insurer. The main point here is that another metric of competition, which is the sum of the market shares of the 4 leading firms, called the 4-firm concentration ratio, is quite high in this sector and increasing over time. And this is before these mergers may go through, in which case we're going to have the orange merge with the blue hash mark, and Anthem, Cigna, United. Humana is not on here. So then United, the green, would get bigger. If you want to compare it to another industry that nationally that is fairly concentrated, you could think of airlines, where the airline concentration is 62%. Okay. Another industry much in the news would be beer because of the proposed mergers, and this is Texas, so it's much everywhere, and that would be 83%. Okay, so beer is a highly concentrated industry nationally. Of course, insurance markets for many customers, not all, but many customers are not national. And some of these players aren't active in local markets, and there are other players that are active but don't enter the top four. But this is just a reflection of what is going on nationally to our healthcare sector. And given time, I'll be very brief and just say it's much harder to track vertical integration. And that's because there's so many different industries involved and no common registries or reporting for them. But some examples, say, would include combinations across different providers. So one of the large for-profit dialysis chains, DaVita, merged with the largest operator of medical clinics, Healthcare Partners. We also have joint ventures that would be considered a form of vertical integration, vertical partnership. There's the Blue Cross insurer in California, Anthem, partnered with a number of acute care hospitals, and they announced a narrow, sort of narrow network, lower priced health plan, and they're in it together, and they cut price 10%. And then you even see some insurers acquiring providers, with one of the examples being the Blue Cross carrier in the Pittsburgh area acquiring a struggling hospital system, West Penn Allegheny. Okay, so I've told you why people might merge. I've told you that they are merging, and now I want to tell you why, so what? Okay, so mergers are happening. Why should that matter? Well, and maybe bigger is better. It certainly can be. The thing is that we have some fairly compelling evidence that for horizontal mergers, that is in the same level, so the same kind of physician practice, the same kind of hospital in a same geographic area, that's part of market definition, the evidence is that that tends to lead to higher price. And there is no compelling evidence that on average it leads to higher quality. And that does not mean, someone asked me, can you give me an example of a good merger? I actually wrote a paper with somebody who approached me from Partners Healthcare, and I'll have a story about some proposed mergers there in a couple minutes, approached me and said, why don't we write an article about a good merger? And I said, great, we'll write an article about a hypothetically good merger. You come up with an example of what is a good merger, so that when they asked us, and they surely did ask us in the podcast, give us an example of a good merger, we came up empty. Now, I do not believe that's true. There have to be examples of good mergers, and please come up and tell me about them. But on average, they haven't been very good for consumers. Okay? And there's recent research, my own included, that suggests that the consolidation hasn't been good for consumers of other healthcare services, not just acute inpatient care. And just to be fair and even-handed, let me say that there's research that suggests that insurance mergers aren't good for consumers either. That in fact, when the insurers merge, they pay providers less, that would be physicians and hospitals, but that the savings don't trickle down to consumers. Okay, so consolidation, the research on horizontal same sector consolidation is pretty negative. What about non-horizontal? Okay, all the everything else and up and down the value chain, we had some really cool ideas there about what might be the motives for those kinds of transactions. The early evidence on that is very discouraging. One study finds that when independents join systems, they raise price. Well, you know, there could be a lot of things going on with that. Maybe independents were financially struggling, maybe they changed the service mix, and so you're not adjusting the price for exactly what they're doing, and so forth. So I'm in the process of doing a study with co-authors, Kate, not Vivian Ho, and Robin Lee, and we're studying not just independents, we're actually studying mergers of systems, and we're tossing out any cases where the systems have hospitals that are near one another so that there might be some horizontal motive, and we're just looking at the bystanders to the transaction. If you're part of a system and your system acquired another system, and the crown jewel of that acquisition is that, you know, two hospitals that are close together or a particularly sizable hospital, we're throwing that out and just asking what happens to you as bystanders. And the objective of that is to try to get around the fact that acquisition isn't random, that sometimes it's associated with things that are going on in your hospital that might otherwise lead you to, like with independent hospitals, be planning to increase price. And we find that if you gain a system member in your state, and you're just a bystander, if you will, not the objective of the transaction, not located near any other hospital that is party to it, prices go up 6 to 9%. So there's something going on with bargaining and likely with market power associated with that transaction, possibly with market power. And finally, what about those physicians aligning with hospitals? It sounds like a good idea because they could share medical records, they could have single protocols, and work together in a coordinated fashion on their accountable care organizations. The research on that so far is also discouraging in terms of price. Okay, prices tend to go up, total spending tends to go up. This research is just beginning. Okay? More needs to be done, but early evidence on this is really discouraging. So in come the antitrust enforcers. Okay? So let me talk about who they are, what they do, what progress they've made, what holes there are, and somehow I have what, like 20 minutes, right? Maybe. Okay. All right. Well, let me start by motivating you. Why should you care about this? Well, first of all, it's in the news a lot, and it's pretty useful to know if whatever transaction is in the news could potentially be a source of concern for antitrust enforcement authorities. Right? Second, it's bad stuff. It reduces social welfare. Right? Third, knowledge is power, and this is the bullet I talk about to my MBA students. Okay? And I explain, look, first of all, it's a bad thing to get involved in a lawsuit. You could be fined. There could be criminal convictions. You want to know actually if the transaction that you're considering or someone you know is considering is possibly anti-competitive, right? Second, if you are aware of that, you might complain to authorities. I've certainly had people ask me whom you could complain to. You might call your rivals out for anti-competitive conduct, call the Texas Attorney General and say, hey, you know what, this physician practice is merging with this physician practice and they're going to extract higher rates and that's the transaction. There's not clinical integration benefits that are going to be passed through to consumers from it. So you can complain about it. You might have to submit confidential information. You could be subpoenaed for it as these transactions are being studied. And finally, you can benefit as a bystander. So if one hospital chain merges with another hospital chain and the authorities say that's only going to happen if you spin off one of the hospitals because it's located too close to another, it's a rival, well, if you happen to have your financing lined up right there, you can get a fantastic deal on these assets where the sales need to happen very quickly. And so there are those who troll the merger news and get good deals on assets. All right, so who are the agencies that enforce laws and study mergers? You might read about them in the paper and say, is this going to happen? Is it not going to happen? What am I, in fact, seeing here? Well, there are two federal agencies. One would be the Antitrust Division of the Department of Justice, known as DOJ, and the other would be the Federal Trade Commission, known as FTC. Those are the federal agencies, and they have state counterparts. Often these will join forces together in filing a complaint to try to prevent a transaction from taking place or to try to sue some parties for engaging in what they believe is anti-competitive practices. Sometimes they will act alone, though. Those are the main statutes up there that are enforced. And the one that is, you're probably familiar with some of these, right? So no agreements and restraints of trade. These are things like cartels or market allocation. Listen, I'm going to take the south side, you're going to take the north side. Nobody's going to build any dry cleaning operations without my say-so. Okay, that would be market allocation. That stuff's strictly illegal. Okay, Section 1 actually can have criminal penalties as well. Section 2 is no predation and no exclusionary conduct to obtain or maintain a monopoly. So the way in which some healthcare entities have gotten in trouble with this is if you're a large hospital and say there is a specialty hospital nearby and you go to the payer, the insurer, and say, look, if you leave that specialty hospital out of your network, I'm going to give you a discount of 2 to 4% on all of your volume at my hospital. And of course, you need my hospital because I provide the full array of services, okay? And that is essentially depriving that specialty hospital of the access or ability to have patients and provide competition to you. So there's a big risk there. You see your antitrust attorney if you think that's happening, okay? And then last is what I'll talk about mostly today, which is Clayton Section 7 says that any combinations where the effect may be substantially to lessen competition, that's when the authorities will step in. They'll do investigations. For large transactions, it's mandatory. For others, it's optional. It's up to them whether they choose to investigate. Okay? And then the outcomes, the vast majority of times, as we'll soon see, nothing happens. Okay? Sometimes they'll file a complaint, they'll come to an agreement, okay, you stop doing that, you stop telling the payer to leave the specialty hospital out of contracts, game over, okay? And sometimes they go to court. Here is an overview, which we don't have time to go through, of what has happened. But I will give you the highlights, which is going to be apparent when you look around you and ask, how did we end up with the markets that we have? First of all, most insurance mergers have been approved. We have a fairly concentrated health insurance industry. Occasionally, a divestiture is required. Here in Texas, in 1999, large insurers Aetna and Prudential merged, and the Department of Justice reviewed that transaction and required them to spin off a health plan called, I think, NileCare that they had acquired the year prior so that they wouldn't have too much of the insurance market here. In particular, their concern was that they would drive down the prices paid to physicians participating in HMOs, and that would result in less access and lower quality care for consumers. The physicians, whenever I talk about antitrust, I will have an aggrieved physician come to me and say, why is it the authorities are all over us when the other guys are so much bigger? And one reason, and this happened when I had the privilege of serving at the Federal Trade Commission for a year, and I actually saw a group of nephrologists, and I couldn't believe it. They actually still happened. But this was in Puerto Rico, and more than 80% of the nephrologists, independent practices, got together, sent the same letter to an insurer and said, we refuse to treat your patients anymore unless you pay us 20% more. Okay? That is illegal. Price fixing, group boycott, collaborating, you just can't do it. It's a per se offense. It doesn't matter whether you have any bargaining clout, like it had an impact or it didn't, you just can't do it. And so a lot of these challenges that have been successful have been from independent groups saying, we want to use our market power, we want to amass our market power so we can have a higher price. That's not legal. Now, we want to get together so that we can achieve clinical integration and have multi-specialty interaction, improve our quality of care for patients, be fully financially integrated, and negotiate a joint price. That's a different story. But not having integration that is reasonably necessary. So it has to be the case that joint bargaining is necessary in order to achieve some benefits. You don't put that bargaining first and then hope that you might have some benefits. And then last but definitely not least would be hospital mergers. And I'm going to tell you a little bit story. I have a few different hospital merger stories, but this one is a new one. Because it's an example of when and this is when I'll talk about antitrust enforcement after, when the antitrust enforcers were willing to have a deal go through, and actually the public and the judge had a say and prevented a transaction from closing. So just quickly on the history of hospital mergers, for a number of years, the Federal Trade Commission, the Department of Justice blocked hospital transactions, and then they lost 6 cases. And that's a very big deal because they only bring 1 or 2 cases a year across all industries that actually go all the way to trial. If you are involved in litigation, you'll know it's exceedingly rare to get to that point that you're in court. So losing 6 or 7 hospital merger cases in federal court is huge. So they gave up. They called a moratorium. And we are not, and this is when I was in graduate school, we are not prosecuting, we're not bringing hospital merger cases anymore. And then some mergers happened, including one one where I live now, Evanston and Highland Park Hospital. Those two hospitals raised their prices 50% after the merger closed. These facts are not disputed. And the FTC, after a couple years, did a hospital merger retrospective and went to court and said, see, we didn't object to this transaction because you kept telling us, the market definition that we were using was too narrow, that all of Chicago competed with these hospitals, not just suburban hospitals, and look, this happened. And the court agreed and said, at the end of the day, you're right, this was anti-competitive, but we can't force them to break up now because so many years have passed and it would be more costly to break up, more costly for consumers to do it that way. So the authorities work really hard at that very first stage, trying to prevent something they think might be harmful, because untangling it later is extremely hard and unlikely. Although there's one case here, ProMedica St. Luke's in Ohio, that really was ordered. They appealed it up to the Supreme Court this year, and they've been ordered to sell the hospital they acquired in 2011. So I haven't seen notice of the sale, but if you've got financing and you desire a hospital in Ohio, you might take a look. Let me give you a little bit of background on a particular transaction because it is an example of what one state has done to supplement its antitrust enforcement arm or authorities, and also to supplement and inform the public so the public can have some impact on what happens in their markets. Partners Healthcare is Harvard's hospital system. There are 10 hospitals, 6,000 physicians, $11 billion in revenue. They proposed to acquire a hospital in the South Shore and 2 hospitals in the North Shore, where most of their hospitals are closer into Boston. I'll show you a picture in a moment. But Massachusetts, a year or 2 prior, had created a health policy commission. They're the only state that has it, and they gave that commission resources and the ability to require some confidential data so they can do analyses of what's happening to costs in the state. And they issued their first report on this proposed transaction. So they have the authority to review proposed transactions and put out a report. Okay? This is their final report of February 2014. They put out a review of the South Shore Hospital transaction. Later, they put one out about buying the North hospitals. And since I know we are short on time, the main takeaway of this map of Massachusetts is that here's where most of the hospitals are. They wanted to acquire this one, and they also wanted to acquire some up here. But they want to acquire this one, and this area here, kind of the medium gray, is in the primary service area of these hospitals as well as the primary service area of South Shore Hospital. So essentially, the Health Policy Commission said, look, you're an academic medical center seeking to acquire a community hospital, but you actually compete with this hospital, and they put up the market shares, and up here in the South Shore's primary service area, South Shore had 26% of commercial discharges, but Partners had 24%. And that wasn't just tertiary, which is where you might expect to see it. They both had a reasonable share of tertiary and a lot of non-tertiary. Yikes. Running out of time. And then the red dots are where the Health Policy Commission actually calculated the prices for all the different Partners hospitals relative to their peers, and the red dots are the Partners hospitals. And this red dot is South Shore Hospital. So they said, look, you're a high-priced system seeking to acquire another high-priced hospital with which you compete. But the Attorney General hammered out a deal with Partners and said, look, as long as you do a whole lot of complicated things, including agree to negotiate separately with insurers for South Shore, separately for Hallmark, the academic medical centers, agree not to raise prices faster than inflation, and so forth, you can let this deal go through. Now, an economist doesn't buy that. Why does an economist buy that? Well, if I'm Partners and now South Shore is in my system, if I raise price a bit more, I know that more patients will be steered to South Shore. And that's fine with me because I now own South Shore. So even if we're not setting our prices to the insurer at the same time, it gives me an incentive to raise price. And by the way, them an incentive to raise price too. So the fact that we're not sitting in the same room together, or that you can include one and not the other, doesn't eliminate the fact that we're in the same organization. And so we're going to internalize those externalities. That's the slide derived from the vertical integration motives that I gave you before. The judge asked for public comments, and it was suggested to me that that none of the Boston area economists were going to submit a public comment, and maybe given my research, did I want to submit a comment? Now, I was on my way to visit my sister in London, and the judge only gave us 3 weeks, so I was a little bit loath, but I downloaded all of those HPC reports, and I read the reports, and I wrote up this long footnoted document, and we only had like 2 or 3 days, circulated it to some economists I know who study both firms and healthcare, including Dr. Ho, and said, please read this. We can't make any changes. You have 3 days to sign it if you want to submit it alongside me to the court, and don't sign if you have a financial interest in this case. And we said stuff like, we don't believe the proposed restrictions included in the settlement will offset the consumer harm that is likely to arise. Okay, here's I was hamming it up with the reporter, and I said, it's an attempt by the Attorney General to remedy 20 years of behavior stemming from the merger that created Partners. This is a central planner's approach to the healthcare system. You're trying to regulate prices, price growth, how many physicians Partners can add to the system, and that's not your job. Either have a case on the merits and decide whether the merger can proceed or not, but this complicated component contracting and whatnot won't be effective. The judge rejected the deal, which is very, very rare for the judge to reject a settlement between parties and an attorney general. I will, given the warning I have about time, skip over some of her comments. Quickly on the myths. Well, many think that antitrust enforcers block a lot of mergers. I think this graph covers it, okay? The red is the share of mergers that they block. Done. Many say that antitrust enforcers don't care about the benefits that could arise from mergers. Of course, there are some mergers that can be good. It's hard to find them, but of course there are. And an example I'll give of what not to do is what the Mount Sinai CEO wrote in the Wall Street Journal, as he said, well, okay, because for efficiency benefits to count, they have to be specific to a merger and they have to be verifiable. They can't be too vague. Okay, when 2 companies came before us at the FTC, they were manufacturers of glass containers. They said, when we merge, we're going to make this container there and save on transport costs. This way, they calculated what the benefits were. Okay? This CEO says, population health management means services must be coordinated, requires hospital systems to provide a full suite of services, warranting expansion through acquisitions of other hospitals, as well as physician medical practices and outpatient clinics, essentially saying, hey, we have a population to manage, so we can acquire anything we want. This would not be considered merger specific, verifiable, though there may be something in there somewhere, but it's not going to cut it if you're trying to get through a transaction that might have anti-competitive consequences. Okay? And then the last thing I'll say is the idea that antitrust enforcers can ensure that we have competitive markets, in spite of the fact that they've had some victories, it's not true, okay? Take a look around you. The agencies have very specific, narrow laws to enforce, okay? They prevent transactions that would lead to a lessening of competition, but not necessarily transactions that could lead to consumer harm or price increases without a lessening of competition. So let me give you an example. Suppose I have a flagship hospital and I charge high prices, but for political reasons, I can't charge prices as high as my real market power should allow. I might buy some outlying hospitals with whom I do not compete, not like South Shore where I compete, but like I really don't compete with them, and say, take us as a system and have these hospitals have higher prices than they truly deserve. Okay? Many would not interpret the antitrust laws to say that that is a violation, because it doesn't lessen competition. It's actually an exercise of pre-existing market power on the part of the large dominant system. So what I'm trying to say is that antitrust enforcers have real narrow guidelines. And the ability for anyone interested in healthcare costs to have an impact requires information. And since the case of Partners, I have gotten requests to write letters to attorneys general and judges and say, hey, this merger is happening in my hometown, and my steel mill is not going to be able to stay in business if it happens and they raise prices. But I don't have any data. Now, I'm not in the business of letter writing in general either, but the Health Policy Commission gave me really rich reports. I could say something. In any random town without information, I don't know the details. So I would just say that sunlight, and that might be what could be done, sunlight is the best disinfectant. Oh, yeah.
How are you doing? Thanks for your presentation. It was great. Quick question. When we talk about dominant players in the industry, I was thinking about it on a more local level. Mm-hmm. So here in Houston, the top 4 hospitals comprise 65% of the market share. Memorial Hermann is number 1, number 2 is HCA, 3 is Houston Methodist, 4 is St. Luke's, which was acquired by CHI based out of Denver. But with that kind of market share and hearing what you had to say, I mean, could you comment kind of on what the impact of that is, having that kind of oligopoly kind of local, mm-hmm. how that impacts the consumers and healthcare costs and things along those lines?
Okay, thank you very much for the question and for giving me the statistics, because in spite of the fact that I grew up in Houston, we're Memorial Hermann, and that's all I know. So my answer to you is it's buried in your question, which is what happens when you have an oligopoly. When you have a small number of large players, there are 2 potential things going on. One is if there really are economies of scale, so that you can deliver better quality. If you're a larger provider, you have a good network of specialists and people on call at the right time and so forth. So there could be some benefits. On the other hand, there's less of a market incentive to pass those benefits through. So if somebody say that there are 3 or 4 main parties, if somebody engages in really tough cost cutting and holds down their price increases, they're going to spoil the well for everyone. Okay, make everybody have to engage in that really tough cost cutting. You can facilitate what we would call tacit collusion more easily in a market that is more concentrated. The market you described is less concentrated than a number, certainly than Boston, but is more concentrated than my hometown of Chicago. And so what I would say is every market is a little different, but in this case, enough number of players that they realize that any decisions they make have ramifications. If I get the proton beam accelerator, the other guy is going to feel like he has to make a big major capital investment in something else. So that interplay can result in higher prices and lower benefits to consumers.
I'd love to get your take on accountable care organizations. It seems as 2 branches of the government are pushing back against integration, CMS is pushing forward with it through accountable care organizations and other contracting mechanisms.
It is good of you to ask, because it enables me to put up myth number 4. Okay, myth number 4, and this happened, and I'll tell you a story. When I was at the Federal Trade Commission, we sued a system, the St. Luke's of Idaho, the dominant system in Boise, Idaho, and they proposed to acquire a multi-specialty practice in Nampa, the 2nd largest town in Idaho. I know these things now. And they were sued because they already had some primary care physicians in Nampa. And by acquiring so many more, they were going to have 60 to 80% of the adult primary care physician market. And that's too big a concentration to have in the hands of any one player, because PCPs, having local PCPs is so important for selling insurance. So the insurers would have to pay higher prices to the physicians. And what the leadership said to us at the FTC, was the following. But the Affordable Care Act says we're all supposed to merge and coordinate, and we think if these doctors are part of our system, we're going to feed them into our central hospital, and we're going to do a better job taking care of them. And so one can march forth, first of all, what CMS says, which is, we reject the proposition that an entity under single control that is formed through a merger would be more likely to achieve the three-part aim. What was the big fear here is that when St. Luke's acquired physician practices, what they did is they would take advantage of a reimbursement loophole where they would add a facility fee in addition to professional fee, and for the exact same service be able to charge more because simply there was a hospital ownership stake in a physician practice. So that's not clinical integration. Then the question is, what clinical integration could they achieve that they really needed the financial integration to achieve? And they argued things like, well, we can't be on the same EMR. But you know what? There are actually ways to interface. They just hadn't really been explored. So bottom line is that there are a number of people out there who work with independent practices that aren't owned but are affiliated, who will tell you that benefits of integration can be achieved without full financial integration. And the problem with full financial integration is once it's done, incredibly hard to unscramble. And once you're all one, you might improve quality, but you could also raise price, and there's nowhere else to go. So that's the same thing about not having the market incentive to pass on gains.
Thank you for your presentation. I had a question about your opinion on the merger or consolidation in the insurance payer area. So is it conceivable that by concentrating the buyers in insurance that you would be able to exert purchasing price pressure on the providers who are consolidating as well?
Yes, that's called monopsony power, and it was the motivation for why Justice required some spin-outs after the Aetna Prudential merger. There is a lot of empirical evidence that when insurers get bigger, providers get paid less. The question, though, is, okay, what is it? There's much less evidence on whether consumers are harmed because the authorities are not in the business of protecting competitors, and the providers are. They're in the business of protecting competition so the benefits accrue to the consumers. If physicians and providers will do the same thing, but they'll just get paid less, okay, then that's something that gets transferred to either the insurers or potentially the customers. So the real question is, when providers are paid less, how do they react? And if they react by cutting back what they do, you know what, I'm going to go to the golf course, or you know what, I'm only going to I'm going to spend 8 minutes with the patient instead of 10 minutes, and that can be documented, then that would be consumer harm. If instead they say, all right, my kids don't get to go to private school, the authorities that doesn't add up for them as a consumer harm.
Thank you.
Could you talk about how policymakers can address some of these competitive issues? I think one thing they did in Massachusetts was for the state's purchasing, they required insurers to have tiered networks.
Yes.
So if you could talk about that a little bit, I'd be very interested to hear your point of view. And then also about barriers to entry in a system. I mean, if you have companies that are charging effectively above market prices, you would normally have a competitor come in and arbitrage away that difference. Why is that not happening in a hospital market that sees significant declines in bed use over time? Enormous declines in bed use just because of shifts in technology.
Enormous declines in?
No, I'm sorry, bed use. So
bed use, okay.
Bed use.
Okay.
So days in the hospital.
All right, so the first one is what can policymakers do, like local policymakers? One is I really believe that if they make some data available to researchers, fund an institute like the Health Policy Commission did, there will just be information there. They don't actually have prosecutorial abilities. They just put out the data and then let the public and competitors use it. So I think putting out data is one. As you mentioned, it is possible to ban certain practices. For example, most favored nation clauses prices of certain kinds between insurers and hospitals that make it very difficult for new insurers or small insurers to survive in a marketplace if they can't get good deals. They could ban facility-based billing, which tax on it just exacerbates this incentive to consolidate and potentially try to undo some of what's happened to date. And as you mentioned, they could create provisions to encourage creation of tiered networks, including forbidding hospitals from having anti-tiering or anti-steering provisions in their contracts, where payers aren't allowed to say, well, if you use Baylor Methodist, you're going to have to pay $150 extra no matter what, anytime you use it. And of course, hospitals don't want that, but insurers who are attempting to control costs want consumers to have incentives to select lower priced care. The second question you asked was about entry, and I'm glad you asked it, because when parties merge and they raise price, if entrants can come into the market, okay, they could bring down price and say, look, physicians are now paid so well, so new physicians will come to the market and they'll drive down the prices, or new hospitals will come. We know hospital entry is exceedingly difficult. There's certificate of need and lots of regulations, so that's unlikely to happen. And in the health insurance sector, barriers to entry, as we've seen with the failure of the co-ops, are also pretty substantial. You're specifically asking about hospitals?
Well, I'm asking, are there any other policy levers that states in particular could look at to help lower barriers to entry, to encourage, well, federal governments to encourage more entrants into the market?
It obviously is going to depend on the market, but I think the certificate of need commissions would need a really, really close look. And I have ideas on how that are a little complicated on how you could encourage insurance entry. But one way you could do that isn't so complicated is through the exchanges. You could default people who haven't made plan selections or whose plans exited into certain kinds of plans, maybe plans that use tiering, maybe plans that have smaller market share but have high quality ratings. So you could take advantage of some of the, and Medicaid managed care could do that too.
Yes, is it possible for the regulators, or do they consider retrospective information, the information that's developed by looking at past mergers and acquisitions of a particular provider, company, whatever, and then seeing whether that the performance following the approved merger met the promised benefits, offered the promised benefits?
It's the answer is yes. It is very rare for a party to have records documenting what they did and what happened as a result. Now, what the authorities can do if they have claims data is they can look. So they can say, look, this hospital system acquired all these physician practices. We see what happened to claims and total expenditure. And so we have a track record of that. Now, if we ask I asked the insurance CEOs this as well. When you made your prior acquisitions, what happened to your costs? You tell me their administrative savings. So what happened? And then what happened to premiums, and knowing that data. But if you had that data, I think it would be a powerful argument in your favor if it were good data.
So then could you make the approval conditional upon keeping the evidence?
That's the problem. If somebody then needs to monitor it, there needs to be some regulatory agency that is in charge, and then they need to fight you to unwind you if you don't do what you said, and then there's going to be some extenuating circumstances where something happened that nobody anticipated, and this is actually what happened at the Health Policy Commission. They had a hearing I went to 2 weeks ago, and they brought through some executives of systems that had made acquisitions, and they kind of raked them over the coals, like, what did you do? And those executives said in advance of the meeting that the fact they were going to be called publicly to talk about what they did had made them do more. So this is an example of how just public scrutiny can create an incentive to do good.
Well, thank you.
Thank you, Dr. Daphne. You know, we hear so much about professors and their ivory towers, and I think Dr. Daphne is exactly the opposite of that. And despite all the criticisms one can make about government these days, it is extraordinary that places like the FTC and Department of Justice can rely on experts like Dr. Daphne to come in and help work with them for short periods of time and try and do a lot in terms of protecting consumer welfare. So we are going to take a short break, and we'll meet back at 11 o'clock for our next speaker. Men's restrooms are on this side, ladies' restrooms are on that side.